I'm Eric Greenleaf, and this is Healing from the Ground Up, a series of conversations with interesting people. Today we have the first part of a two-part series, Healing the Wounded Warrior. And my guest today is Teresa Allen, a licensed marriage and family therapist in private practice in Oakland, and at work with the drug treatment program New Bridge Foundation in Berkeley. What kind of people do you see, and what do you make of these problems?
Well, I often see young men and young women who have returned from 3 or 4, maybe 5 deployments overseas. And they might be from the Air Force or the Marines or the Army. But they have developed an addiction, and they also have a co-occurring PTSD diagnosis. So PTSD very often comes with substance abuse. So folks who are trying to deal with the intrusive memories or the nightmares or all the symptoms of PTSD turn to alcohol or drugs to try to medicate themselves. And so when they come to us in Berkeley at New Bridge, we've got both problems to deal with. It's, sobriety has to come first, because you can't really work on yourself or any problem if there's a substance abuse issue going on. So, but they're sober when they come to us because we're a drug treatment program and everybody's sober there. So that is kind of solved in and of itself for the 28 days that they're with us. But really soon after that, we have to teach them to turn down the volume on the PTSD symptoms. So to be able to come out of an agitated state or to pull themselves out of a really numb state. So we teach people right off the bat to do what we call grounding exercises. So they can, I think of it as turning down the volume on a radio, the volume of the upset. We teach them really simple distracting techniques so that by the end of the first week, they know I can kind of manage these symptoms and I'm ready to do what I have to do to learn about addiction.
How is it that you and your colleagues understand the kind of ordinary course of trauma, seeing something violent, losing a friend in combat, or any of the experiences that are so unusual compared with civilian life? What do you make of those?
Well, when something traumatic happens, it usually takes all of us a little bit of time to get over it, usually maybe a month. But for some people, the reaction stays, and 4, 5, 6 months into it, they're not better yet. And those are the people that we consider the PTSD diagnosis correct for. About 25% of young men and women who are deployed come back with PTSD. So
that many?
Yeah, about a quarter.
Wow.
But that means that 3/4 have in some way retained their beliefs about themselves and their balance and their ability to move on with life. So it's really interesting to note that, it's hard to say, well, what makes you fall into the 25% and what makes you fall into the 75%. So there are some factors like frequency, how many traumatic experiences have you had? So that's what's different about these young people is from Vietnam, is that they've been over there 4 or 5 times, at least 2. And so you've got not just 1 or 2 or 5 traumas, but multiple traumas. So those folks are much more likely to come back impaired. That's probably a very, very common thing that the soldiers come back with. I let my buddy down, or I didn't lead my platoon the way I wanted to. And the people who are affected by that kind of experience may have already had pre-existing similar experiences where they might say have had alcoholic parents where their job was to take care of everybody, and that's their main identity. And so if they haven't been able to do that in the military while they were deployed, they would see it as a kind of a, well, now they're convinced that they really didn't do their job right. So that kind of person might end up with PTSD.
Although, is it the case that somebody who was trained in unit cohesion and in backing up the other man or woman in combat would have those same feelings without the pre-existing alcoholic or
Sure.
bad family?
They might.
Yeah.
They might. And they might come back with symptoms, yes.
Yeah.
It's hard to predict.
And is it known, I don't know that you would know this and I sure don't, but is it known whether among the 3/4 who do not show up for treatment, there's any sizable amount of people struggling inside themselves with memories of horrible things seen or done from the ordinary experiences of combat?
I think probably so. The 25% figure is actually the number that developed active symptoms, not just the ones that might come to treatment. I think the amount that come to treatment is far fewer than even that. So that's what we're trying to do at Newbridge, is just to offer people a way to get some treatment that they might not have had through the standard military structure or the VA, or there are also vet centers around the country that young people can go to for assistance. It's not necessary to be an actual discharged veteran. That you can go even if you're not in that category. So there's lots of places for help, but still far too few people are getting it. There are wounded warrior programs in the military that are designed to do exactly that for people who have been given this diagnosis and they need special help in the transition. There's a PTSD treatment center in Palo Alto, and the vet centers in particular are good at helping people transition, to find resources in the community and to help other vets. I think that in recovering from PTSD, one of the most important things is to be able to connect with other people who are also recovering or who themselves are helping people who are recovering. It's just as with substance abuse, the recovery is in the community, and that's what we want them to be able to do in the final phases of treatment, really.
And I know that as you do that, the commonplace among people, especially people who are familiar with psychotherapy, the talking cure, is that talking it out and saying what happened to you and unburdening yourself is essential and initiatory in dealing with awful events in your life. Do you find that to be true in dealing with post-traumatic stress disorder?
Well, not initially. Definitely it's not the thing to do in the beginning stages of treatment. Most people think that's what they might be able to do to help someone who is in trouble with PTSD, because they think about therapy and they think, oh, you go in and you talk and then you feel better.
Yeah, that's the common assumption.
Right. But in the case of trauma, it's actually not the case, and the rules are reversed. Eventually you want to do some processing of the trauma, but in the initial phases, it's actually counterindicated. It's not a good idea. You want people to be able to, first of all, experience safety again, to be able to connect with their own bodies and to pay attention to their own signals coming from their body, and to find places and people where they feel safe. And so I was talking about the grounding techniques earlier. That's the first thing people need to do. If they know how to turn down that volume and to be with someone and feel safe, then they're ready in a while, maybe months, maybe years it could take, to actually look at what happened to them, and then through various techniques. I use EMDR, other people use different kinds of methodologies, but far enough into the treatment span or the sequence, then you can talk in small chunks that are small enough to be safe and to process effectively. But you don't want to go straight into it in the beginning.
Your remarks imply that terror, fearful terror for your life or the life of your buddies, or for not being protective enough toward the people under your care, and all those things, that fearfulness kind of carries past the traumatic event itself for at least a large proportion of people. So they may be walking around a bookstore and hear a sound and react with tremendous hypervigilance, startling, fearful palpitations, and ducking for cover or being aggressive,
Yes.
as they would if they were on guard and heard a sound in the jungle, say.
Right.
And you see that sort of thing. I think when you said that safety is the most important initial thing, not disclosure.
Yeah.
Till you feel safe, the story is itself frightening.
Too scary, yes.
Yeah.
And I heard someone yesterday describe PTSD as you go around and you don't feel anything, you feel absolutely nothing until suddenly you feel abject fear and incredible anger. So those are the two kind of reactions. People can shut down and sort of dissociate that part of their experience that's frightening, and they're just not in tune with life. That's why soldiers sometimes have this strange look in their eyes where they're just not there.
Yeah.
But on the other hand, they have experiences, like I said, abject fear or abject anger. So it's a hyper alert state that you don't know how to turn off.
And in fact, in something as stressful as combat or death or injury or even just fearful alertness for months at a time, alertness for danger, an IED, someone on the same side who might betray your trust, all of that has the characteristics of stress response, the normal stress response, freezing, as plain dead, or being unreal, fighting, being aggressive to try to deal with the stress, running away, but you can't always do that if other people depend on you.
Right.
And one more that's not given much notice, but seems to me crucial: affiliation, calling for help, coming to find safety with others.
Yes.
Is another normal response to stress. And of course, when people are isolated in their feelings, when they can't talk to their families or their friends, or their buddies are in another state,
Yeah.
then they're in trouble, because the stress reaction is the only real response. It seems to me, anyway.
Right. And there's such a huge stigma. I mean, I have men tell me all the time that they were really afraid to acknowledge this problem. And so even if they are interested in getting some help, there's a tremendous cultural stigma associated with this in a culture where bravery is the ultimate value, and men and the women are very afraid to acknowledge that, yeah, this has happened. And so that's why the first thing we tell people is, this is a normal response to an abnormal set of events. War is not anything that you and I will ever have to deal with, probably. It's an unusual and abnormal experience for them. So if they can get that, if they can accept that, then it's much easier to affiliate, much easier to say, oh, okay, let me meet somebody else who's got this, and let me talk to you about what's going on.
I remember an interview with a world-famous mountain climber, an Austrian guy who had climbed all 7 of the highest peaks in the world by himself without oxygen. And the interviewer was gushing, you know, oh, how wonderful he was, and what was it like to make these brave and difficult climbs. And he said, in response to all the admiration, the first thing you must understand is you're always scared. Mm-hmm. And I thought of that when you're speaking about these very brave soldiers, sailors, airmen, medical corpsmen and women, drivers on these roads with people blow them up all the time.
Right.
That it. Do you imagine it would help if that were part of the training to say, by the way, everyone is scared, witless out here?
I think so. I think probably it is part of the training. I don't know for sure, but I think that it is normalized, and that, you know, young people expect to be afraid, and that they deal with it through connecting with their buddies. You know, that's how you deal with it, and that's the cohesive bond that is so important, and the bond that sometimes gets ruptured. And one of the hardest things about coming back is losing those buddies. You're not with them anymore. You don't have the esprit de corps that you have when you have a common goal, and so that's really tough for them as well as the trauma.
Yes, and as you say, some of the veterans have also lost themselves. They have that faraway look in their eye, and they've lost the connection with their own children or wives or husbands through long absence and repeated deployments.
Yes.
And I was thinking again as you spoke about how natural it is when terrified to have these things we call symptoms, dissociative symptoms, hyper alertness, sudden, you know, startle and quick twitch reactions, aggressiveness, and that the natural progression of fear involves exactly what you said, to return to safety with others. Because that's what's breached. If you're walking side by side with another person and they get blown up, who is safe?
Yes, yes.
The other thing I was wondering about the discussion of fear, which is a normal response to being in combat, I would imagine, and the response of guilt as a normal response to feeling you had let down a sacred trust of caring for another person. And you know the therapy term to pathologize. So I was wondering about your opinion, since you work so closely with these men and women who have suffered so much, about whether it makes any sense to have discussions about how normal it is to feel guilty, alert to more danger, afraid, a nightmarish fear, and how ordinary it is to have repeated visions or flashbacks of something so unusual and startling that, you know, an explosion, a amputation, whatever people do not and should not see in their ordinary lives, but do.
It's difficult because the experience of PTSD is like somebody has changed the channel on you and you're on another channel. And so to convince somebody that that's a normal response is hard. But we try very hard to explain that these are normal symptoms to abnormal events, and that there are ways to turn them down so that you can manage them. And if the person has had some way to be active in the trauma, then often the result is much less of a problem. For example, I had a man tell me that he had been he had to stay in a 10-foot square area. He was pinned down for 18 hours or whatever. And that not being able to move was what generated the disorder in him. Whereas his compatriots were out there moving around on a convoy, whatever, doing things.
Yeah.
And so if there's any way in which people can get active and begin to move again, then it often will help.
And in the recovery from PTSD, is it helpful to do that same thing, to again have care for someone else or for a pet or for a family member, to have something to do that, Shakespeare's line about sleep, it knits up the raveled sleeve of care.
Yes.
Is there a connection that knits up the raveled sleeve of trauma?
I think so. I mean, once people are safe, once they've had a chance to resolve some trauma, then the final stage really is reintegrating with the world. And in this case, that means other people who have suffered, returning to the community, regaining your ideas about the world and how you were connected to the world before. That's what we want folks to do towards the end, when they're really ready to reconnect with the world that they left behind. I mean, they will never be completely the same. In some sense, it's an ongoing battle to fight with, to manage PTSD, but if you can do that part, the connecting back to the community, then you're very close to being healed.
Yeah. And do you then directly involve the families or churches or workplaces of people before they leave the 28-day program, or not? Or?
Well, our soldiers often come from far away, but those who are close, some come from Sacramento, they are able to bring their family members to our family night once a week, and we do family work there with the family members. Again, it's in the very beginning stages of the treatment, so there's much more work to be done, but we do bring them in right away.
And that seems to me, as I listen to it, very central to people's recovery of their ordinary life and feelings. Because otherwise it's like the expression from World War I, a no man's land, in which there's only danger, and you're forced to relentlessly go forward into horrors for no advantage.
Yes.
And in those circumstances, of course, the original PTSD, what's called shell shock, that people would freeze up and start shaking, be unable to carry out their missions, or would, again, become belligerent to everybody, even their buddies, be in fights, shoot people, and so on, and be ever on watch and troubled, clearly troubled by nightmarish things they had seen, done, and heard about, too.
Well, that's why people need treatment, so that the families also can get education about what to expect and the normal course of how people get better. If the wives and husbands can know that, then they aren't in the dark about what's going on. But the interpersonal realm is definitely impacted drastically by these symptoms, because the normal give and take and attentiveness between a couple is broken for a while.
And I would imagine it's very frightening to the spouses and kids to have dad or mom come back and be angry and unreachable.
But the thing I would really want to stress is that people can get better.
Yes.
That recovery is not as simple as telling your story, or even as simple as getting sober. You have to, do treatment for trauma and do treatment for substance abuse. But people can absolutely get better. There is, in my view, tremendous hope for people if they get the right kind of help, and it really truly is out there.
And your therapeutic notion of dialing down the extremes without changing the nature of the trouble is very reassuring in some way.
Yeah.
Because if someone said, oh, you shouldn't be so angry, no one knows what to do with that. They already know they shouldn't be so angry or so scared or so guilt-ridden or sad. But if you could dial it down so that they're sad, angry, scared, guilty, loving, hopeful, uncertain, then that's more like normal psychological life.
Right. And often you just have to distract people from the intensity. If someone's in a flashback, or if they're in an intense period of anger, we teach them to do really silly things like just name what you see in the room, or count backwards by 3 from 100, just to get their mind off of it. And that's really important. It doesn't sound very complicated, but it's tremendously helpful to get people started with treatment.
Yeah, I like this very, very much because all of the very lurid symptoms, the things that attract people's attention, can be seen as distractions from ordinary life.
Yes.
And I always like the notion that you would distract the person from the distraction. You'd overcome the distraction with distraction.
Yeah.
And to give something doable matches your other interest in making each person more capable and less helpless.
Yes, exactly right.
That there's something the man or woman can do even in the midst of a fearful spell.
Right. And when you get that sense of personal agency back, when you know I can do A and it leads to B, then that's a tremendous step forward, that you have power over this thing, whatever it is, that you can do things and you'll get a result that will help you.
Yeah.
It's very empowering.
It also seems to me as I listen to you that you start with soldiers, let's say, who are kids, really, barely out of high school, or it's not 40-year-old people who sign up in the volunteer army necessarily. So they don't know much. They've never been anywhere, done anything. And you teach them to be mutually reliable with their buddies and to do very difficult things. And so it's very good to know that there are programs like Newbridge, that they won't get in the corner of alcoholism or just be a set of symptoms and fearful to others. So I want to thank you very much, both for the good work you're doing and for coming and talking today. And I know that there are local places in Marin County, Roanoke Park, and so on, that veterans can call.
Yes.
And they will appear on our screen as we complete our conversation.
Yes, a couple of different vet centers in San Francisco and Marin.
Good. Well, this has been Healing the Wounded Warrior, Healing from the Ground Up. I'm Eric Greenleaf with Teresa Allen. Thank you for watching.